Argueta, and I am the 2022 to 2023 president of Eta Sigma Gamma, the Delta Rho chapter here at Cal State Fullerton. This year's theme for our symposium is Addressing Cancer, Reproductive, and Mental Health Disparities in Southern California. I would like to give a special thanks to all of our speakers and student presenters who are here to help spread awareness and advocacy about these issues. I would also like to thank the Department of Public Health at Cal State Fullerton and Loma Linda University for sponsoring this event. I will now pass it to the chair of Department of Public Health here at Cal State Fullerton, Dr. Michelle Wood.
Good morning, everyone. I am Michelle Wood, Chair of the Department of Public Health, and it is my great pleasure to welcome you to the CSUF Eta Sigma Gamma Second Annual Virtual Public Health Symposium. Today, we welcome experts from Southern California to share their perspectives as we examine cancer, reproductive, and mental health disparities and their impact on quality of life and general well-being. The event is hosted by CSUF ESG, Eta Sigma Gamma. ESG is a student-run public health educational honorary organization. And students, please consider joining ESG if you haven't already. Thank you for being here. Thank you for your commitment to public health and to understanding and addressing health disparities. Now, please get ready to hear from our expert speakers and enjoy the symposium.
All right, now we have heard from our department chairs. Welcome. And I want to welcome all of you to the symposium today. I am Bo Park, co-director of this year's Public Health ESG Symposium. We're so happy that so many of you could join us today. And I would like to highlight how we face many challenges in reducing cancer and reproductive and mental health disparities. And today we have opportunity to hear from the experts in the field tackling these challenging issues. So I'd like to extend a warm welcome on behalf of ESG and Department of Public Health at CSUF. And Dr. Mahmoudou and I will be moderating the chat. And during the speaker session, please hold your question until the end, and we'll be moderating those questions, and Juliana will present those to the speakers. And now I would like to pass it on to Dr. Mahmoudou.
Yeah, good morning, everyone. I am Lohua Mahmoudou, Assistant Professor in the Department of Public Health and co-director for this symposium. We welcome you all to this wonderful symposium. It's been a long time coming, and we are happy to bring this symposium and get different speakers who share different perspectives when it comes to public health issues on cancer, reproductive health, and mental health. And then we are also happy to have students who will also be presenting and also sharing their research work and then their perspective when it comes to various research in which they have been actually undertaking. Again, we warmly welcome you all to this year's symposium, and then we hope you enjoy the symposium. Thank you very much.
Okay, so we will go ahead and get started on our first topic for today, which is cancer disparities. Our first speaker is Dr. Tan Nguyen. Dr. Tan Nguyen has worked in higher education since 2009. He's a clinical professor in the Department of Family Medicine at UC Irvine, where he serves as the department's Director of Medical Education. Dr. Nguyen is a Dean Scholar who was involved in teaching medical students from first to fourth year in the Clinical Foundation course, Family Medicine Clerkship, and Sub-I electives in Gender Diversity, Health Equity, and Medical Humanities. He also serves as the faculty advisor for the Asian Pacific American Medical Student Association. He has been recognized with the UCI SOM Excellence in Teaching and UPMA Physician of Excellence Awards for his interest in creating innovative learning for students and incorporating diversity, equity, and inclusion training. So without further ado, please welcome Dr. Tan Nguyen.
Dr. Tan, you're muted.
Good morning, everyone. I'm going to share my screen here. So I work in a FQHC, which is a federally qualified health center. For the first 10 years or so, we were in this trailer right here on Harbor and the Freeway 91 in the heart of the community. So
Dr. Gelareh Sadigh is an associate professor in residence and director of health services and comparative outcome research in the Department of Radiological Sciences at the University of California, Irvine. Dr. Sadigh's major clinical interests include imaging of the brain and spine, particularly brain neoplasms and white matter diseases. Dr. Sadigh's research interests encompass financial hardship, price transparency, and cost of care discussion, healthcare utilization, care adherence, and mental health and health disparity. She has a track record of successfully receiving research funding. Her work in these areas has served to identify current gaps in patient-centered healthcare delivery. So without further ado, please welcome Dr. Gelareh Sadigh.
Thank you very much for the kind introduction and also for invitation. And I know it's hard to follow Dr. Wayne talk, which was great. So I'm going to a little bit change gear and talk about medical financial hardship, which is a health equity issue, especially also in cancer population, but not necessarily limited to cancer. You see that with many other diseases. So as mentioned, I'm a neuroradiologist, but a lot of my research is encompass public health and is not necessarily related to diseases of brain and spine, because issue of medical financial hardship is an issue that, again, as I mentioned, regardless of which body part is involved, patient can experience. And many of us, when we go see doctor, we get that surprise bill and we sometimes double think that whether we can afford that care or not. So that's going to be the topic of discussion for today. These are my disclosures. So let's start with social determinants of health, and Dr. Wayne went over this as well. So we all know that social determinants of health are conditions in the environment in which people are born, they live, they learn, they work, and it can affect a bunch of downstream things, like even like patients' quality of life outcomes and how they function and how their health situation is. And when you look at the social determinant of health frameworks, so we know that our society interacts under paradigms of race, economic status, what the gender is, what is the sexual orientations are. And when these paradigms are basically taken into public, they frame policies and they result sometimes in institutional inequities. And then as you go downstream through this platform, it can affect patients or people's public living condition. And then these upstream inequities can also define the living condition that people live in and how their behavior is going to be, like in terms of their nutrition, their physical activity, and how it's going to affect their health outcomes. So that's why it's very important. Like if we can't just focus on health outcomes. And if you want to focus on health outcomes, you want to improve like how the upstreams inequities are in the society. So let's talk about financial toxicity and what is it and why we're considering that a health equity issue. So financial toxicity, some people call it financial burden, some people call it financial hardship, it's an entity that has become very common in the last 10 years. They define it that people usually experience this because their out-of-pocket cost for their medical expenses is high. And when they become sick, obviously they lose income because they can't work or they become disabled. And so because they lose the income during or following treatment, and on the other hand, they need to pay a very large volume of bill. So that's the time that they experience financial hardship. The term initially was introduced in cancer population just because in the most recent years, a lot of chemotherapy and immunotherapy or newer medication have been approved, which are helping with the cancer treatment, but have been very expensive. And sometimes they were not covered by insurance, and people are like dealing with 10,000, 20,000 of bills. But I mean, as we see this spectrum, it's not limited to cancer patients. Again, a lot of other diseases experience financial hardship, especially chronic diseases. Like an example of that is patients with multiple sclerosis. They are also on immunotherapy and very expensive medications. So again, like studies have shown that like you can see it with many other diseases as well. So the financial toxicity has 3 different domains, and here is like a conceptual framework that shows these 3 different domains. The first domain is that when someone experiences financial hardship, they start having psychosocial symptoms. What does that mean? So if you get a large bill you can't pay, and then you are still sick and you need to go get the treatment, you start feeling anxiety. Can I pay my bill or not? So the stress, the anxiety, depression, so those are the psychosocial domain of the financial hardship. The next piece that's going to be involved is what we call material domain, and that's basically medical debt. So again, like you're dealing with financial hardship, you need to pay things. So how are you going to pay that? You're going to start decreasing on your basic spendings. You're going to like skip your vacation because you want to save the money for your treatment. You're going to use your saving or retirement accounts. If you have a car, you may sell it. If you have a home, you may refinance it. And in the extreme cases, I mean, people even file for medical bankruptcy as part of financial hardship because they cannot afford care. And then the third domain is the behavioral domain, which is usually the last thing that is being affected. Like usually, especially if you think about the cancer patient, they're going to first all get all these debts from different places so that they can afford cancer. Like, I mean, their last goal is not being adherent to their treatment. But once you can't afford it, then that's going to be outflow to the behavioral domain, and patients starts like showing care non-adherence, meaning that, like, for example, if you have a prescription for a medication, they start taking it like every other day as opposed to every day so that they have it for a longer period of time. They may skip, for example, their imaging exam. They don't get MRI because they want to save the money to pay for their medication. And you see this like in not necessarily only focus on the cancer treatment, for example, itself. I mean, patients, this is going to affect other treatments as well. So they may even skip their PCP appointment or taking their blood pressure medication to save the money to get like basically treat the more important thing in their mind, which is cancer. Or they may skip the preventive services because, I mean, again, they want to save the money for what they prioritize in that stage of their life. So in terms of the scope, studies like there was a study in 2015 that shows 1 in 10 American actually experience financial hardship, but the prevalence is higher than this. We are currently doing research using the National Health Institute survey data from 2021, and based on that data, actually 50% of Americans report financial hardship. So definitely it's more common than 1 in 10. And the other issue is that usually like 2/3 of medical bankruptcy that are filed in the United States, like 2/3 of bankruptcies in general, they're tied to medical expenses, which is again another manifestation of how prevalent the medical hardship is in the United States. We did a study actually a couple years ago, and we just surveyed 100 cancer patients to see how common financial hardship is in them. And of these 100 cancer patients, we found that like 20% of them reporting, like 20% is a pretty large number for cancer patients, reporting a non-adherence to the care that was recommended for them. Around 15% of them were saying that they delay filling of their prescription medication to save the money because they can't afford the care. 4% of them, they were not getting their imaging because they wanted to, because of the cost concerns, and they wanted to save money. 12% of them were skipping office visits because, again, they wanted to save money. And studies have shown that if you think about cancer spectrum, actually financial hardship is much more common in patients who have metastatic cancer, as opposed to early stage cancer. Because first of all, the patients who are metastatic, the chances that they are disabled or they have lost income is much higher. And then they are usually on much more extensive treatment. So, I mean, usually early stage, you have a period of surgery, chemoradiation, and you'll be done. But for your metastatic, like, I mean, majority of the things might be on a much more extended period of time. So you're going to be dealing with much higher number of bills and more expensive medication. This is a study that was done by Dr. Shankran and her team at the University of Washington, based on a cancer community oncology practices that are affiliated with SWOG, which is a cancer cooperative group. And they looked at only material financial hardship. They were actually checking patients' credit scores and see what are the changes in the credit scores over time, because obviously as you accumulate medical debt, so your credit score goes down as well. And they were seeing the patients who have metastatic colorectal cancer, if at 3 months after diagnosis, their rate of their medical debt, like around 24% of them have medical debt. At 12 months after diagnosis, around 71% of them had medical debt, which is, again, like very important thing, like when you think about a larger effect of this on patients' care. However, as I mentioned, in patients who are early stage, we don't see this much progressions. Actually, we are currently doing a study, again, based on some data in early stage colorectal cancer patients in community oncology practices across the US, which are affiliated with ECOG Akron Cooperative Group. And we see that in early stage, like usually the degree of financial hardship plateaus at some point. So as I mentioned, financial hardship also can affect the use of preventive services. So we all know that for breast cancer screening, women that are 40-year-old and older, they need to get a screening mammography every year. And usually a screening mammography is currently an essential health benefit, especially after Affordable Care Act came in 2010, and it's covered by all the insurances as a service that is free. But there are some older insurances that still charge patients for the screening mammography. And there was this study that looked at how much patients are paying out of pocket for their screening mammography is going to affect patients coming back in the subsequent year and get their screening mammography. So like for every $100 increase in your out-of-pocket expense, the chance that you come back next year is going to decrease 1.9%. And then the other thing is that, so whenever you do a screening mammography, with every test, you're going to have a false positive rate, meaning that the radiologist may see something on your screening mammography, and then they may call you and ask you to come back to do some additional tests, like now getting a diagnostic mammography or getting an ultrasound or even sometimes biopsy to make sure it's not cancer. And in 10% of the cases, like, I mean, like in a basically 10% of the cases that that thing may not end up being cancer. So it's like more of a false positive test. And studies have shown that for any out-of-pocket costs that patients spends for these callbacks, when they come back to do those additional tests, the chances that they come back the next year also going to for their screening mammography, for their preventive service, is going to decrease again 2.7%. So again, you see that like the bill that you receive going to affect on your behavior, on how you take care of yourself and your family members, and again, like kind of an emphasis on the issue of financial hardship. So financial hardship, it has been shown that it affects health outcomes. There are a lot of studies that have shown that it can affect patients' quality of life. The people who experience more financial hardship, their quality of life is lower. It can affect the amount of the symptom burden, the amount of symptoms that patients experience. Again, we are doing currently one study based on the National Health Institute survey. And what we found that basically people who are experiencing financial hardship have lower satisfaction with life. Their perceived health status, general health status is lower, and they are experiencing more depression and more anxiety. Also, even studies have shown that the people who experience financial hardship are the chances that they die is higher, their mortality rate is higher. There was one specific study that looked at the people who declare medical bankruptcy and their survival, and the people who actually have bankruptcy have higher chance of dying compared to people who don't have bankruptcy. And also the issue of financial toxicity is not only limited to the patient. It's actually limited, it's at a family unit level. So it involves the caregiver of the patient as well. This is based on a study that our team did a couple of years ago. And we looked at, again, cancer patients. And then we asked the cancer patients to identify a caregiver for us. And we surveyed the caregivers as well, and to see what is the degree of financial hardship in the caregivers. And the caregiver financial hardship was correlating with cancer patients' financial hardship. And basically, when a patient has cancer, it's not only affect themselves, it affects all the family member. And it's also affect family members' adherence to the care, because again, all the attention gonna be on the patient. The family member now skip their own care or their own office visits or their own preventive services to save the money, to bring all that money to the focus of the patient. So with all this, we know that financial toxicity is more of a health equity issue. So because like when you're diagnosed with a chronic illness, it can have significant financial impact on patients and their family members. And even if you're insured, depending on what type of insurance you have, depending on how much is your deductible, it's not a guarantee that you're not going to experience financial hardship, like especially people who are underinsured or have very high deductible. Those are the people that are actually experiencing also a higher prevalence of financial hardship, because they have a lot of out-of-pocket costs. And obviously, if you're uninsured, then the financial impacts are more devastating, because you're starting with lower resources and your health outcomes are poor. I want to also put a plug in biomarker testing. You hear about it, I mean, a lot more common now in the cancer world. They do biomarker testing to find these targeted therapy to treat your cancer. But again, going back to the issue of financial hardship, so biomarker testing is only Medicare is only covering for certain types of tests, what they call next generation sequences. And there are still some private payers that don't cover biomarker testing. There are still even Medicaid that doesn't cover the biomarker testing. And you see that now you're dealing with variability in coverage, and how much your out-of-pocket cost going to be, and how this is going to increase that disparity gap we are talking about in terms of who can use these targeted therapies or not. Like you are talking about why cancer outcomes are different in different population from different socioeconomic status, because of course, like the people who are starting at a lower socioeconomic and they have Medicaid, for example, or they have certain insurance, I mean, they are not covered and they can not get that best treatment that we are talking about. So I want to quickly also go over some of the social determinants of health that affect financial toxicity, and also how we can decrease financial toxicity. Studies have shown that the type of insurance that you have, the income that you have, the race that you have, and with the race, I want to put a plug on it because there are questions on that, because a lot of times the issues that we attribute to race are not actually race, it's actually the neighborhood that people live in and how much health access they have. So they can all affect the financial toxicity. And changing gear a little bit, and I know we have maybe a couple more minutes left, is how we can decrease financial toxicity. We talk about how prevalent it is. But what are some of the interventions that we can use to mitigate financial hardship? And I want to focus on a couple more important ones. So one is screening for financial hardship. So currently, screening for financial hardship is not happening. It's very variable in different institutions. It's not a common practice. There are a lot of unknowns that who needs to screen for financial hardship, when the screening should happen, how often the screening should happen. And even if you identify the patient, there are limited resources that, okay, I identified someone who is at risk. What should I do with these patients that are at risk? So if you think about just cancer centers, and these are the basically NCCN member institutions, there was a survey that went out a couple of years ago. And in cancer centers, they mentioned that they routinely screen 76% of patients for financial distress. But like, again, then you come with like community oncology practices and other practices, and the rate of screening is much lower among these other practices. And even like from a cancer center, we still have 25% of your population that are not being screened for financial distress. But the idea is that actually, like, you want to have the screening, first of all, happening at every encounter. Like, I would argue, again, as a radiologist, why we should only screen patients when they go to their cancer clinic. Why this patient going to come to radiology and get image, and why we can't screen that patient during that encounter. The patient going to have their PCP appointment, why we can't screen at that encounter. So every encounter should be used as an opportunity, the same way that when you check in and every encounter, they ask you whether, for example, you had to travel in the last 2 weeks to make sure you don't have COVID. Or the same way that at every encounter they ask you, have you had fall in the last 2 weeks, to make sure you don't have, there's no basically elderly abuses going on in the, or any sort of abuses going on in your household. So why can't we screen for financial hardship that same way? But again, like, as I mentioned, there are a lot of work needs to be done in terms of how often this screening should happen, and is it the office staff responsibility to do the screening? Is it the physician responsibility? And again, like, what encounters like we need to screen patients for? This is a study that actually currently we are doing at UCI. It's an ongoing study. We are screening patients in radiology encounter, and right now we have around 340 English-speaking patients, 53 Spanish-speaking patients, and 17 Vietnamese-speaking patients. And we didn't only screen for financial hardship, but we are also screening for other health-related social risks. And actually, just based on these numbers, you see that our Spanish-speaking population are having much more problem than our English-speaking and Vietnamese-speaking population, and the rates of these health-related social risk is much higher. But when we ask this population, have you been screened at any other encounter before? Like, in general, like, only 11% of our patients were screened in other encounters at UCI. Only 24% of our Spanish-speaking population were screened before. And when we asked them, is it acceptable for you that we screen you during the radiology encounter? Majority, I mean, around 80% of them were okay with the fact. So, like, I mean, again, like, a lot of times there's this stigma is going that, oh no, we shouldn't screen at this encounter or that encounter. So I think this should become a common practice where you do the screening. But now our challenge is that, okay, again, we screen, what should I do with that information? Because radiology doesn't have a social worker that I can refer the patient. And like, I need to refer the patient back to the ordering provider, and they refer to social worker. I know we are short in time, so I'm going to stop there. There are some other interventions that can be used to mitigate financial hardships, such as cost discussion with the patients, offering them financial navigation, offering them education to improve their insurance literacy. But I'm going to stop there to leave some time for question and answer as well. Thanks very much.
Thank you so much, Dr. Sadigh, for your presentation. We can go ahead and open the floor to any questions that anyone may have. You can go ahead and enter them on the chat. And actually, while we wait for any questions, we'll go ahead. There's one here for Dr. Tan Nguyen. It says here, what would you say health literacy and language barrier? Would you say health literacy and language barrier is one of the biggest challenges reducing health disparity in Orange County?
I guess I can speak to my two clinics that I'm at, which is in Anaheim and Santa Ana. Yes, it's huge. So the requirement for our physicians or healthcare professional, or including the medical assistant, to apply for a job to work in our clinic, they have to speak Spanish. So that's one. And then we work extensively with the IT department and medical records to help create education materials in different languages, which has been really helpful compared to before, when people just Google stuff. But now we have, multiple languages and simple health condition that we can print out for the patient. So I usually instruct my medical assistant to actually take a highlighter, highlight key instruction, have the patient do teach back, and let us know that they understand the instruction. So it's a huge component.
Thank you. And then for Dr. Sadigh, it says, what financial support or opportunity can cancer patients get access to, especially people who are financially disadvantaged?
Right. So there are some financial assistance programs in terms of copay assistance with their medication. There are some pharmaceutical companies that even offer free medication. So that's in terms of covering their medication. But there are also some other programs that help with living expenses. Like transportation is often covered by certain types of insurance. If you're living far and you need to come for radiation therapy like every day or 2 times per week, so they cover your transportation, or they give you money, gas money, if you have your own car and you want to commute with your own car. There are other funds, financial assistance programs that help with your living expenses, paying your utility bills, even paying your rent. But all of these requires a financial navigator or a social worker basically go over what your income level, what you are eligible, and then look for all these funds that are available and basically connect you to those funds and fill application programs for you. I also want to put a plug in. There are some national nonprofit organization. An example of that is Patient Advocate Foundation, Family Reach. Patients can self-refer themselves. Like there's, certain smaller community practices that there's no social worker to screen patient or to basically refer patient. Then in those cases, patient actually can self-refer themselves to these additional organizations, and they can help you complete these application programs for you. And actually, the study that we are doing at UCI, again, we don't have a social worker in radiology, and we had specific population, like some of our patients were actually asking, so what should I do? And we were referring them to Patient Advocate Foundation as well. So.
And then thank you. So there's another question here for Dr. Tan Nguyen. It says, given your position as MD, what risk factor is considered the greatest disparity for cancer treatment? Why and how does it impact survival of cancer?
Treatment. Luckily, once patient get diagnosed with cancer, a lot of our patients could qualify for Medicaid. We also have a Vietnamese American Cancer Association that can provide support. I would say one of the hardest or most difficult issue for patients is coordination of care. There's so many providers involved. And so as a family doctor, I have to make sure that the cancer doctor communicating with the radiologist, the radiation oncologist, discussing with the social worker and the psychiatrist. And so different specialists might give the patient different treatment or medication. And sometimes if they're not in the same system, like a lot of my patients, because of Medicaid, they don't get to see the UCI specialist, right? So then the specialists are different in different areas of community, so they might not communicate to each other. So sometimes patients get confused. But if it's all in the same system, then the electrical medical record can be seen easier. So then patient will always come back and say, oh, this doctor said this and the other doctor said this, what do I do? So as a primary care physician, it's kind of like a quarterback of medicine. I can help review all the record from different specialists and then help the patient decide the plan.
Thank you for your response. And thank you to both of our speakers, Dr.